eating.
That's right.
I wasn't bringing that up. I just brought up the chocolate piece.
Talk a little bit about some of the things we're going to touch on today. Kind of the dashboard, and then some around recruitment, some celebrations there. Kind of the financials where we ended at 18, and then we're at, a little bit about the budget for fiscal year 19, and kind of July, obviously our first month in the fiscal 19 budget. A little bit about healthcare environment, and then a little bit more on Make It Easy, and then anybody know what MHN stands for? Yeah, we'll talk a little bit more about that and some developments and what that's becoming and what that looks like. Some upcoming events, and then also some celebrations, and there's some celebrations throughout all this as well. So, talk a little bit about what the org leader dashboard looks like right now, really around employee injuries. Remember, we really want to talk about and find ways to ensure that we're keeping all of ourselves safe, whether it's using equipment that we've bought to keep our staff safe, or being smart about wet floors, or what's the next injury, what's the next safety thing that could happen. Looking at those, catching them, making sure that those events never happen. That's the best way to do it, keeping us all safe. So, and then around our sustainable growth and efficiency, really around our labor compensation. Remember, we always talk about what's our biggest expense? Us, yeah. And so what do we do around making sure we're good stewards? We know that we've got to make sure that we're spending money to take care of our patients, and that's us, but also making sure that within our revenue, keeping that ratio as far as our goal. And of course in July, because revenues were down, we didn't hit that mark. So a lot more work to be done in that area. And then really around exceptional patient care, how are we giving the best care to our patients? What's their perception of us? And those types of things. So at least right now, we're hovering right in where we want to be, which is good. One area that we're still working on, what that'll look like, if you remember, was diabetic patients last year. This year, we're really kind of looking at what should that be. And two themes here, two thoughts. One is we've always kind of talked about our healthy community being all those people that we serve. The other is really being our community, us. And so there's some discussion about what that would look like. You know, should we be talking about how we take care of ourselves? In healthcare, you know, the 20 plus years I've been in it, one of the common themes is we're terrible at taking care of ourselves, great about taking care of our patients, not so good about ourselves. So really trying to figure out what that might look like for us as well. So more to come on that as we kind of solidify and continue to have some exciting discussions, I would say, about that. So
They're healthy.
Healthy, yeah, I would call them healthy, yes. Operating margin, just a little bit about that. We were budgeted in July to lose about $20,000. We lost about $232,000. We knew July, I think most of you have heard me say, it's kind of the worst month to start any fiscal year in any type of business, always slower. You know, we had probably, I'd say about 1.5 providers gone for the month when we had the holidays. Talking about holidays and then PTO, people gone, those types of things. So, any questions around the leader report? Recruitment. Usually, I just met with the auxiliary at 1 o'clock, and I usually start my discussion with them with the words, "Oh, we're in the process of recruiting a physician." Didn't start that way today. We're at full staff. Dr. Singh obviously started first part of August. That's a big celebration. Allie's back from maternity leave. First time in a long time we've been fully staffed as far as providers. So that's a celebration. That's good. We're excited about that. And then the other part is really trying to use less contracted labor. And when we talk about contracted labor, it's really around. There's some contracted labor we want to keep.
You're only coded.
That's right. We're keeping her. Gonna keep Chris. But when you look at like the nursing facility and med-surg, when we've got those companies that we hire, so we're paying the companies, and of course they're making quite a bit of money on top of what they're paying that staff person to be here. I know that Rachel was here in I think my first CEO update, and she talked about that it's been, I think she said, don't quote me, about 4 months since she's used contracted staff. She's at full staff now. I would rather be paying our staff than a company to do that, so it's great. And our dollars go a lot further, so it's nice to be able to do that. And then the UR, or the position, utilization review position, has been filled. A couple other ones have been filled too. So excited about that. A lot of celebrations within that. Any question around recruitment? Fiscal year 18, just some financials. We lost at the end of the year about 1.1 million from operations. Sounds like a big number. When you think of depreciation, we had 2.8 depreciation that came off that. So if you think about it, it's a non-cash. It's not like we have to write a check to this company called depreciation. It's really just has to come off our books because, if you think about our building, when it's first built, it's worth so much money. Anybody buy a car? I used to say as soon as you left the parking lot. I think now as soon as you get in it, it starts to depreciate. So that's what you're doing, is you're writing off that depreciation, and of course that's, it's not worth as much. And the biggest part of that 2.8 is really around our electronic medical record. That was about 2.4, 2.5. We took that in 3 years because it goes pretty quickly. If you think about the building project was 17 million, and some of that will be depreciated off over 10, 15, 30 years. Bricks and mortar, it lasts a lot longer, it doesn't outdate as fast. So now the upside is we took it in 3 years. It hurts as far as the depreciation, but it also ends up in the cost report, so we get that back a little bit quicker. So when you take that into consideration and work that back out, it's a lot better number, obviously. Total income after tax, our tax money from the county, we had a lot of positive $166,000. So the upside is, and I think there's a slide that's later on, but during last year we paid off, we talked about our $17 million investment in our building. We made our last payment ahead of time. We're actually 10 years ahead of when we were supposed to pay off, because we've made some additional payments along the way. We had the opportunity to, a lot of times we'll take our money, we'll put it in CDs. The sad thing is, even when we take $500,000 to the bank to get a CD, you're still like under 1% interest. It's pitiful. Our loan for the building, which was a good interest rate, it was like 4.6, it adjusts as it goes, but so we're able to pay that off, say that interest, and save some money. So versus just keeping it in the bank. And our cash flow, as Connie knows, is still good because she sends me a report every week of where it's at. So appreciate that. Our budget, when we thought we looked in the crystal ball and back in 17 to make the 18 budget, was to make about 1.4 million. Obviously we didn't hit that. A lot of that was around volumes, around payments, those types of things. So fast forward into 19, we really budgeted from operations about a loss of $812,000. When we did this budget, a couple things, very conservative with our volumes, and we didn't have Dr. Singh signed at that time. So I was in the process of talking with him. We were working through that, but we hadn't signed him. And typically the rule of thumb is until you sign, you don't count those volumes. So I think we're very conservative. I think we'll do better than that. Now, having said that, we already lost about $233,000 in July, but July typically is our worst month. It'd be nicer if we could start healthcare in January when everyone is sick and everyone's using services, but it's not the way it is. Our fiscal year starts in July. Usually, typically, is the worst month of the whole year for you. So, and when they roll the budget, which it's all split out evenly, we were supposed to have a loss, like I said, about 20,000. So, our volumes already are up. If you listen to the numbers and see the numbers, even from last month, they're up. So, which makes sense. We're full staffed, an additional provider, that all ripples down. Any questions there? Healthcare environment, a little bit about that. You know, a lot of you, I think, have heard me in my soapbox about Medicaid. It's still broken. I'm a little disappointed when I watch what commercials I do watch. I don't watch a lot of them on TV. I like to fast forward through them, but not seeing a lot as far as in the governor's race. They haven't really latched onto this. A little bit about mental health, but not a lot about the Medicaid. I'm a little disappointed about that. I think IHA, Iowa Hospital Association's working and trying to get a little bit of focus of, hey, what are you going to do? I know that Hubble has said if he was elected that he would change it and go back to the state, but there hasn't been a lot of discussion around that. So I was hoping for more. Maybe there will be more as it gets closer. So still dealing with two companies, two MCOs. Part of what's happening now, of course, is they're going back and saying if somebody was seen in the ER, and they'll take that money back, saying it really wasn't necessary. You should have waited, should have seen it. It's not a good use of resources. You know, the ER emergency room is the most expensive, which is true. I agree with. Don't penalize us. Unfortunately, what happens is they just take the money back from us, and there's no discussion with that patient about, hey, next time, why don't you do this? Or how about this? Or have you thought about that? So there's a big gap, and there's been discussions about that. And starting this fall, they're going to start looking at any of the level 4s and 5s, the high levels in the emergency room, and really questioning if that was needed. So in one sense, they're saying you shouldn't have used it, and now at the high end, when people do use it, they're going to question that and whether they want to pay that and make that difficult. So, and then Wellmark, some of you have heard that Wellmark is doing a lot around same-day services. So we just purchased a new 3D mammogram. Great opportunity to come in and have your mammogram done, and sometimes at the same time do a bone density. So you're not coming twice. Makes sense. You know, at one side we're saying, hey, we want to make things as easy as possible. We don't have to make you come twice. Unfortunately, Wellmark says that's really good, but we're only going to pay for one service. And so that's an issue. And the gals, and as Crystal knows, and Megan, they've been working on how can we make that work, how can we do those types of things. And what we've seen Wellmark now do is add therapy services to that. So if you think about PT, you know, you're in for physical therapy, typically you're coming maybe 2-3 times, you know, Monday, Wednesday, Friday, doing your physical therapy, doing your work. Physician says, hey, you're in on Wednesday, let's do an MRI, see if we're getting to where we need to be. Wellmark says, that's great, but we're only going to pay for the one service. And they never pay for the most expensive service either, so.
Maybe we should offer mammals and bone densities over the midnight hour.
Yeah, yes.
I was kind of thinking that. I don't think that's a bad idea.
11:59, you can do your mammogram, and we could even do better pricing and still be ahead. There you go, Chris. Yeah, we'll just call Crystal in and have her do that.
She'll be a real peach.
Yeah. We'll have to get to the self-adjusting mammograms then, because they'll be even harder. We're doing it right now. We're involved in a Medicare ACO, Accountable Care Organization, which is all an upside and has very little to do with how we're getting paid, but it does allow us to be able to figure out how to work the system, how to do things, how to move our targets. And because of that, now we're going to work with Wellmark and become in a Wellmark ACO first part of January. The other part of that is there's upside if we do what we can to move the mark and hit the metrics. If we don't, there's a downside to where we would get paid less. It's hard to believe they could pay us less, but yes, they would.
That's it.
So,
Hospital-based too.
both, I believe. Yeah, we're just doing the paperwork now, so I appreciate that. So we'll have those targets. We're working through those and be able to do that. We believe when we look at the documentation, there's actually in North Iowa, there's 6 hospitals out of the 8 that are going to be joining that, and it's the rural track because how we're paid compared to how the bigger hospitals are paid is different. So it allows us to be able to do something a little bit different. We're still under the umbrella of Mercy Health Network, ACO, but it's an attachment for the rural clinics, or rural hospitals, excuse me. So we're in the process of doing that, doing the paperwork, getting that signed, getting it blessed by all of our boards, and then the Mercy Health Network board as well, to hopefully start first part of January.
So what are they going to be looking at?
There's a number of indicators, and we'll start rolling those out, so what those will be through Wellmark. Make it easy, a couple things around that, just as reminders, really around does it make it easier for the patient? I know we're talking on both sides of our mouth. One minute we're saying we're trying to do this, but the payers aren't letting us. The other side is we're trying to do it because it's the right thing to do. Obviously the payers and us don't always align, so we're trying to figure out how to make that happen. The neat thing is everyone can contribute. Any department can have and has had and has submitted, and we've put in place different things to make it easy, so that's exciting. And the goal is really around making it, as we say, for the patients. We've kind of looked at and asked for the focus to kind of look at the Latino population. How can we make it easy for that group? We've had some great things around that, whether it's having things translated that we use every day so it's easy for them. Probably a big area is really around our website, trying to do some stuff with that. Really around interpreters, how do we make that easier? On our iPads out front, when you register, it is, I think, 3 clicks, and you're talking with an interpreter. It's on the iPad, so those types of things are easy. We just went to the auxiliary today at 1 o'clock and asked for the interpreter on wheels for them to purchase that. We've been using one from Mason City. We've had great examples of how that's worked, so we're going to be able to do that. So just quicker, faster. We also had nurses that asked when I was doing this at noon if they could get it to where, right now they have to call somebody, those types of things, and somebody has to call them back. And now what we're going to do on their phones really is where they can do a conference call with our interpreters, our interpreter. So we've got a product that we already have and we've been using. So I think that'll make it easier and faster. So
Some of these things have always existed. It's just people asking the question and giving them the knowledge or the directions or the ability to be able to do them.
Yeah, and a lot of times just reminding them, here it is, here's how easy it is. I had an opportunity to meet with one of the schedulers, a couple of the schedulers this week, asking them, what are the barriers around this, the Latinos. Obviously language is number 1, number 2, and number 3. And so I said, well, what do you do? And, oh, we have this, and, well, can you show me? And she says, well, I haven't done it for a while, but we actually had her, it's like, oh, yeah, boom. It's on the iPad, so she touched the screen over here, the button, and it came up. Oh, well, I think it's on here somewhere. Oh, there it is, the interpreter, and it came up, and, oh, it's Spanish. So it was a way to affirm with her how easy it was, too. It's like, oh, yeah, that's so cool. It's so easy. So a lot of neat things. So kind of focusing on the Latino, but anything that comes up that we can make it easier for our patients is really what we're trying to do. So, any questions around that? MHN, what's that stand for? Kind of give it away here, don't I?
You asked earlier.
I know.
It says it right under
3 o'clock. I know, but sometimes people are asleep by now. Yeah, so. Mercy Health Network, as you know, for many years, we've had relationship and management agreements with Mercy North Iowa and Mason City, kind of our triage, kind of our network. We've had most of you have been, if not all of you, have been involved with affinity groups with that, with North Iowa. About 20 years ago, the Mercies in Iowa came together, whether it was Mason City or Sioux City, Clinton, and then Dubuque, Central and Des Moines, came together and signed kind of a loose agreement that says we'll work together, you know, we'll try to play well in the same sandbox, you know, we'll try to work on things that might help us. So we kind of existed that way for loosely about 18 years. About 2 years ago, they said, you know what, in order to be able to work in this environment, hence the slide I showed you, healthcare environment, we really need to do something different. At that time, they came together and signed an agreement to become Mercy Health Network LLC, Limited Liability Corporation. And for this to happen, Trinity Health, which some of you, if you read anything, most of you hopefully don't, but since I'm a healthcare geek, Trinity Health is one of the larger Catholic healthcare groups in the U.S. And then CHI, which is another large, so they're like 1 and 2, 2 and 3. It kind of depends on where you're looking at and how, if they're counting beds, revenue, or whatever. They've come together and said, you know what, we want this to happen. And so they've agreed, because CHI, Catholic Health Institute Initiatives, and owns Des Moines. And then if you think of Trinity owns Sioux City and Mason City. So we have two parents that came together and said, we want to make this happen. And what they've said is, we are so committed that in the writing, if they decide to walk away from this venture, it's $50 million apiece. So if Trinity says, you know what, we don't want to do it, we're going to walk away, it's $50 million. That's their commitment. You know, CHI to get out of it would be $50 million. So I think what they're saying, not that anyone's going to walk away and take $50 million, this is how committed we are to make this happen. And we want MHN to do this. In the past, what has happened is a lot of times, and Tanya can attest to this, so for quality indicators, she was doing quality indicators for Mason City, North Iowa, and then also doing quality indicators for Mercy Health Network. And so you're duplicating it. What we're going to be moving towards and have already for quality, it says, you know what, we're going to do it for Mercy Health Network. So we'll see more and more of that. Altogether, it's 20,000 employees, over 300 clinics, over 40 hospitals in the state of Iowa, from the west coast of Iowa to the east coast of Iowa, north to south. It continues actually to grow. And so the neat thing around this is, and somebody asked me earlier, well, you know, we were just talking about, Vicki just met today talking about our health insurance. What are we going to purchase for health insurance? In time, we're talking about all of MHN buying health insurance, which then is a bigger market, bigger volume. You spread that cost out amongst all. Right now we're in a pool, but not to that size. It'll be a bigger pool. Or why are we even buying insurance? We're responsible for, right now, we cover 30% of the state of Iowa. Could be covering all of our own employees. So why are we not self-insured, you know, and those types of things. So you start to see, as you become MHN, some of the bigger things. Rolling forward, you'll see in the fall kind of a branding that'll come out. You know, Unity Point, if you look at Unity Point, you can always tell it's Unity Point. They've got their brand. They've done a great job of, that's a Unity Point facility. You'll see that more and more with our facilities as we move forward. We're not going to be changing the FGH name. It'll still be Franklin General Hospital. Might be doing partner with, I'm not sure how that's going to roll out with whatever that new logo is, but you'll know by the logo that it's part of. And it's a great job when they show Mercy Health Network. They usually show a slide, and the slide is completely filled with different hospitals and entities that MHN, Mercy, whether it's Des Moines, Mason City, Sioux City, are involved in. And it's a plethora of different logos. So when you look at it, it's like, are they the same or not? Are they? And so in time, you'll know that. So when you think of, and the idea is, when you think of healthcare, you'll be thinking of whatever that entity is in that name. So, questions? The other neat thing about that is, as we roll forward, a lot of you are in affinity groups. Those become statewide affinity group. So the knowledge you have right now is limited to the 8 hospitals in North Iowa. And we already have a compliance group that Janine sits on, quality, Tanya's been involved in, Ron's been involved in. Now it becomes bigger, a little bit harder to manage, but just think of all the brain trust that's in there and the resources that you have. So I had an opportunity, I was in Des Moines yesterday, and Marcia Smith, who's the attorney for MHN, says, yeah, I used to be able to call one place or another place. Now it's like, oh, if I have something, all of a sudden my library, my resources now become the whole state of Iowa. So it's kind of exciting. Questions? So upcoming, some neat things that are coming. Monday, August 20th, what's that? Anybody know?
Party for the providers.
Yeah. Open house for Dr. Singh and for Ali. So kind of exciting to be able to roll that out. Just another way of marketing them, letting them know, letting the public know that they're here. Anybody ever heard of this Wolf Eye Clinic? Over the past year, our cataract surgeries have plummeted. Dr. Meyer really is not doing much here. We've known that, so the last 6 months we've really been working on trying to find an alternative. And we actually had a great problem. We had 2 companies that were interested, and so we had to work through that and figure that out. We settled on Wolf Eye Clinic. They do a lot of work already with Wood Vision here and in Iowa Falls, obviously. Excited to say that in September their first clinic will be here, and in October the first surgeries will happen. And I think the first day they do surgeries will probably do more than what Meyer has done, Dr. Meyer has done in 9 months, maybe even a year. So that's exciting to be able to increase the volumes there, and I think a great service. We think that we'll also be able to maybe do some things that haven't been done here, not just cataracts. So another thing that's nice about them is that they'll be coming on a kind of like a 3-week rotation. Most of us in the room haven't had cataracts surgery done, but you don't usually do just one eye. And Medicare says you got to do that second eye within 4 weeks. Dr. Meyer came on a 4-week rotation. So we only usually got one eye. Now in a 3-week rotation, we'll get the second eye as well. So not just more people, but more eyes that'll be done, so that's great. What used to happen is the other eye ended up going in Mason City and being done, so that's going to be good. Pink Ribbon Night, anybody know about this? Anybody heard about it? A lot of rumors around it.
Are we close to getting your hair pink? Do we know?
No.
Crystal.
I think we're about
$160, $170, so we've got
a long ways to
a
go.
long ways to go.
Yeah, yeah.
$160, $170.
That's all it's in. Yeah.
800, I think it was.
Need to be 800, so got a way to go. So yeah, they're doing a little bit different. You know, this has always been an event that happens at the high school. It's a volleyball game. This year it's with Humboldt. I found out at noon, I think, and Megan was with us. And usually sometimes it's Iowa Falls, so it's but it's going to be Humboldt. This year, changing a little bit. Instead of having the departments put the baskets together and taking the time to do that, and then bringing them. Really, the ladies have said, you know what, we'll do that. So what they'll be doing is collecting the money. Obviously, if we collect about what the money that was spent on the baskets last year, it's going to be about $800. And if they raise that, then I guess this happens. The other part is the fact that it's going to be washable.
It will be.
It's going to be washable. When I met with the providers this week, Dr. Loffer says, well, maybe we'll have to switch out the dye or whatever. So I will be hand carrying it to make sure that Crystal uses the washable.
Maybe she donates
But
the right amount of money and be willing to do that for
yeah, yeah. The other part, yeah, we'll skip right past that. And the other part is if we reach the $800 to buy the baskets that'll be used during that night for the auction, I will personally donate, after I've had my hair dyed, another $500 on top of that that'll go to the donation up and above. Now, somebody had asked, and what is this for? Really, what we'll use the money for after it's been raised is for gas cards. Gas cards for anybody that we know of that's going to wherever to have treatment for breast cancer, any type of cancer, those types of things. But the ladies do a great job now in radiology. Is if we know that there is a diagnosis and there is somebody that has breast cancer, they're sending the gas cards. In the past, it was always like, well, if you come and you ask, we'll give them to you. Amazing, all of us Midwesterns are too proud, so they don't come. So we found that sending them, and I'm sure that they send a letter and things like that.
Yeah.
And that, so really just being proactive and sending them, because it's a lot of miles, a lot of traveling, as a lot of you know. So hopefully, yes, creating some excitement. It's going to be fun. Hopefully, not excited about doing that, but I hope I have to. So it'll be great. Be for a good cause. Some celebrations. Obviously, Dr. Singh on board. Allie back from maternity leave. So we're not looking right now for a new provider, not in need of a new provider. Long term, obviously, when Doc Hansen says, Barbara, let me stay home a little more, we'll be looking at that. But again, we talked about the facility project. We paid that off 10 years earlier than was projected. We saved a ton of money on interest, so that's great. Over 100 Make It Easies have been put in place, and I think we've seen where those have affected positively our staff, or not our staff, but our patients and our staff as well. Just some things we don't get to talk about a lot. Some of our staff that's been out, Angela had the opportunity to present with a group of folks on at Community Works at the summit this spring in May. So that's kind of cool. And then Deb Rosberg, our CFO, got to present at Multiview. She's done some neat things with Multiview and had some opportunity to do some teaching to folks at that event in Nashville, I think it was, right? So it's good. Other celebrations? Any others? I think we had a baby on MedSurg, another baby, he's coming in September. So that's always fun. Questions?
Are they going to be in a specialty clinic, Ropi clinic? Are they going to be in a specialty clinic to see patients at all?
Yeah, right now I think we will. That's where they would be, see some of them.
Do we have a date that they would be doing surgeries, like continual?
Yeah.
Not like, I mean, a date, like Monday, Tuesday, Wednesday.
Yeah, I think they're finalizing what that'll be. So, and they may already have, but I just don't remember.
I just can't remember either.
Yeah, because they've got a good rotation on that. So, but
It wasn't Wednesday.
yeah, won't be Wednesday because everybody's in there on Wednesday. Yes, yes, good point. Yeah.
Dr. Tolman's been busy too.
Yes.
You didn't mention that, but that's.
Yes, thank
I
you.
think we've done more ENT
T.
stuff since she started than we probably have the last 3 or 4 years
Yeah.
combined.
Yep.
So that's
Part of that goes back to the Dr. J and Jalukar being on the same day and great friends, but didn't want to share.
She's here every
time.
other week and can do stuff every other week
Yep.
in the morning.
Yeah, so she's doing, and we bought some equipment updated some equipment for her, so that's good that she wanted.
And Dr. Adams is doing good stuff too.
Everyone seems to love him, so
Yeah.
it's good.
Patients are liking that. Good time with Adam being here and being able to do the system.
Yeah, yeah,
Because we'll do the CT like 2 or 3 days before, and they'll do the system on Monday. They
Yeah.
really like it.
that's good. And yeah, so a lot of those, and then really trying to work on, Dr. J's kind of has slowed down a little bit. Also looking at the surgery department in Mason City is up to 5 surgeons. Been a long time since they've been to that. And Brittany is doing maybe some work here. She does a lot of work over in the west side of our network, but trying to find a way that she could be here on the weeks that Dr. J isn't. We had looked at in the past, and Mason City agreed to have like a locum come in, but people loved Dr. J, didn't know the locum, so they didn't really work that well. Even our doc's like, well, we'll just wait till Dr. J comes so we can work her into the rotation. Then she's seeing clinic as well, and then also doing the surgery. So doing some work on trying to make that happen too. So, other questions? All right, thanks everybody.